This is part 2 of Module 4, again going toward Exam 4. And this is a fairly short part compared to the other ones we've been looking at, but it begins with, and actually begins and ends with the EKG reading system, that we want to kind of analyze a systematic approach to reading an EKG, and generally a 12-lead EKG. And then I'll complete this part 2 with a review for that exam. The EKG reading system is something that everybody should use, so that you go systematically through an EKG and kind of follow a checklist as you do that. And if you do an EKG reading system, and there's one of these actually on the back of the small text. There's a system for reading EKGs, and if you follow a system, you will not miss anything. And if you just kind of look at the EKG and try to pick up a few random things, you can actually miss things. But if you follow a system, that's a good way to do it. So for exam 4, you want to memorize the reading system, and then on the exam you'll have a 12-lead EKG where you'll apply the reading system and kind of go through your checklist and just make your interpretation, write that up based on your system and what you see on the EKG. So for this system, you have several parts to it, beginning on the next slide. And you can look at any electrocardiogram that we've looked at throughout the course. In fact, I would recommend that you would try a few of these and just maybe practice a reading system. And you can, this is a system, again, similar to the one on the back of the small text, but a little bit different. And, just follow these slides for the reading system. One EKG that you could look at as an example, but look anywhere, is page 10 in the course pack. Would be a good example of an EKG, and I'll refer to that a little bit as we go through the system. But again, you can try any EKGs and maybe multiple ones. So you start out in general, and you pick up the electrocardiogram and ask yourself if there's anything life-threatening. You don't want to get too much into a system where you cannot determine if the patient is having a problem because you're taking too much time on a system. So you want to look at the EKG for anything life-threatening. These would be things like asystole, ventricular fibrillation, ventricular tachycardia, maybe extremely rapid supraventricular tachycardia, maybe extremely rapid one-to-one atrial flutter, rapid atrial fibrillation, things along those lines where, it's very dangerous for the patient. And usually as you're reading it and you have the patient right with you, you'll be monitoring their symptoms also. And then you analyze what you're looking at. Is it a 12-lead? Is it a rhythm strip, or is it a combination? For the general reading system, you're generally looking at a 12-lead EKG. But it could, we do have rhythm strips that you would analyze, not so much in this context, but it's a possibility. Or sometimes a 12-lead actually has a rhythm strip on the bottom, so it's a combination of a 12-lead and a rhythm strip. So basically, what are you looking at? And then you look at the quality of this. Is it something that has a lot of artifact, or is it something that's fairly easy to read? Usually the EKGs at rest that come right out of the machine are usually pretty clear and good quality. And if you're doing exercise, maybe you might have a decrease in quality, like that. And then you want to look at lead placement to make sure that the leads are on right. You can always check the patient and look at the labeled leads, but one way to do this is to look at lead 2 should be primarily upright. In lead 2, upright P wave, upright R wave, upright T wave, and lead 2 is the usual situation. So oftentimes I'll just look at lead 2 to see if it's looking right. In AVR, usually it's projected downward. Inverted P wave, inverted QRS complex, inverted T wave in AVR, because that's on the right side of the body. So if those things are everything upright in lead 2 and inverted in AVR, that's a pretty good clue that things are on in the right positions. Now there could be exceptions to that where maybe they are on correctly and they could have abnormal exceptions, but generally they follow that pattern. And then you want to look in V1 through V6 and see a progression of the R wave to where the R wave is very small in V1 and tends to get bigger throughout the V1 through V6, usually peaking at about V5. And if that's the case, then probably your leads are in good shape. You want to check the calibration mark and to see if that's at usually set at 10, and if it's present. So if you're looking at an EKG, follow those steps. If you're looking at page, say, 10 in the course pack, you can see that there's nothing life-threatening. It's got reasonable quality with a 12 lead. There's the leads look like they're on right, and there is a calibration mark present on that. And then you look next to the rhythm and regularity. Do you have P waves, F waves, or nothing? And P waves would be where you would have a sinus rhythm generally. F waves would be, for example, atrial fibrillation or atrial flutter. And then if you don't have any, you could have things like VTAC, VFib, asystole. So you want to see what kind of rhythm is occurring, and is it regular? Is it happening in a regular pattern? So for example, atrial fibrillation is not regular, and normal sinus rhythm is regular. You want to see if there's a P wave associated with with each QRS complex. And is there a P wave conducting each QRS? If you look again at page 10 in the course pack, you have it's a sinus rhythm with a P wave associated with every QRS complex, and it's under the category of a normal sinus rhythm. And again, look at any EKG, and hopefully a lot of these to get a lot of practice with this. The next step on the next slide is to look for the rate. And is the rate normal, meaning 60 to 100, including 60 and including 100, or is it bradycardia, where you are under 60 or 59 or less? Is it tachycardia, where you are 101 or more, like that? And you want to make an analysis of the rate. If you're thinking in terms of an EKG on page 10, you can see that the rate is in the normal area, and again, you have a normal sinus rhythm with a normal rate, like that. And then the next step, step 4, is to measure the intervals. And the first one you would measure is the PR interval, and again, that should be 3 to 5 small boxes. And if you have that PR interval that's too short, you have things like WPW or LGL. If it's too long, you have first-degree AV block. But you want to look for the PR interval. The QT interval is where you want to look at the measurement of the QT, and that should be, under normal circumstances, 10 boxes or less, and to be normal. And if that's too long or too short, you have a lot of different situations throughout the course that would give you that. Then you look at the QRS complex, and is that normal? Is that 1 box to 2.5 or 3 boxes? Or is it too long, or is it really, it doesn't often become too short, but it could be too long, and that could be a problem if you read that. So you want to read the intervals. If you do have a prolonged QRS complex, and you do have left bundle branch block, LBB, and this is also consistent with what Dr. Bing has on the back of his reading system, on the back of his small text, you actually have to stop your reading at that point. You would do everything up until this point, and then you would say, left bundle branch block is present, therefore I cannot do further interpretation. Stop at that point. If you're looking back at another EKG, say that doesn't have left bundle branch block, like page 10 in the course pack, you'll see that the intervals are normal looking, and left bundle branch block is absent, so you can continue the reading to step 5. The next thing you want to look for then, step 5, is infarct, injury, and ischemia. And this was a whole section in this course. And mainly you are scanning the electrocardiogram for Q waves, looking everywhere for Q waves, and STT wave changes, meaning STT waves that are ST segments that are depressed or elevated, T waves that are flat or inverted, all kinds of stuff like that. And if you look in any example, but if you look at page 10, again in the course pack, there are Q waves present in the inferior leads. So in this area, that's actually an inferior wall infarct that you could start to interpret. And that's a big finding that you would want to pick up. But again, if you're practicing a lot of EKGs, the findings could be different. The big finding could be an infarct or injury or ischemia, or it could be something else, like left bundle branch block or something else that's coming up in the reading system. The next slide, step 6, you want to analyze axis and rotation. We have done a lot with axis in this course, and you just follow your mechanism for determining axis. And if you do have axis deviation that's unexplainable, you actually can make your call of a hemiblock based on that. Left anterior hemiblock or left posterior hemiblock based on axis. And you can come up with a number for the axis too. The rotation, your answers here would be normal or clockwise or counterclockwise, and you can read for rotation based on the EKG, looking at the precordial leads. So again, if you're following an example, you'll see that you have either the presence of axis deviation or rotation problems or things like that, or maybe everything's normal in that area. Next, you look at step 7, which is hypertrophies. And this is where you want to look at all 4 of these, right atrial hypertrophy, left atrial hypertrophy, right ventricular hypertrophy, or left ventricular hypertrophy, and to determine if they are present. One of the big findings on an EKG would be LVH, or left ventricular hypertrophy. And if that's present, then you would want to make that comment at this point. And then you look for other things, step 8, and this would be things like electrolyte and drug effect. Do you have any kind of electrolyte abnormalities like, say, peaked T waves, other U waves, stuff like that? Do you have a drug effect on there, maybe like ST segment scooping or prolongation of the QT interval? Look for all that stuff. Is there any kind of pulmonary effect, either acute or chronic? For example, low voltage. Do you have U waves? Do you have ectopic beats? Ectopic beats would be things like PVCs. So you go through and read all that kind of stuff as far as other or miscellaneous items. And then finally, on the system, you put it all together and you do an interpretation. So the next slide is step 9, and you write up what you see. So for example, you could be writing up an EKG that might have normal sinus rhythm, maybe a rate of 75, period, inferior wall infarct, period, everything else is normal, period. Something like that would be some type of interpretation that would be read into something or written down or typed in, and it's a kind of a final diagnosis or interpretation of what you see on the EKG. So again, on your final exam, you'll have a 12-lead electrocardiogram, and you want to take pretty much everything that you've learned in the course and put it into this reading system, and then step by step interpret that 12-lead electrocardiogram. So I would do, get some 12 leads and do some practice, and there are lots of examples throughout the course pack, and the answers are given, and just try to get some practice with that. If you work as a clinical exercise physiologist or go into the medical field in other areas, you could be interpreting electrocardiograms. Sometimes this is done with a machine, but these machines are notorious for making errors, so it should be looked at by a human just to be confirmed or verified with a reading system. So that concludes the material for Module 4 in Part 2 in Exam 4. Now I want to look at the next slide, where we want to talk briefly about what to expect on Exam 4. And anything in this module is testable unless I designated it as future learning or other items to think about later. And there were just a few examples of that, not too much. For example, that area on sensitivity and specificity, future learning, things like that. But most of what we talked about in this module, almost everything that's described here or you're finding in your material, would be testable on this exam. You'll have 25 multiple choice, true false type questions, more multiple choice than true false, and that'll be worth 50 points, so 2 points each on that. You'll have some critical inquiry questions, including skills and EKG recognition. That'll be worth 50 points. And 10 of these 50 points will be kind of thinking questions that will make you think comprehensively about the entire course. So as you go through this exam, then you'll be looking at EKGs and making your interpretation, for example, your reading system in the 12 lead, and then, other EKG interpretations, but also, thinking comprehensively about, what's been kind of building throughout this course. And what you've learned in Module 4, and then, to a degree, some of the building of the course, and, to a slight nature, some cumulative questions that have to do with what we've talked about and what you've read throughout this course. An example in that area would be to look at the concept of the R wave and S wave ratio in V1. And so normally it would be, you would have an R wave that's smaller than the S wave in V1, but you could have abnormal reasons for having an R wave larger than the S wave in V1, and we've kind of built that material throughout the course. So that would be kind of an example of a cumulative question on the final exam.